Clinical applications. To understand the indications and limitations of liposuction, different types of fat must be distinguished. The structural organization of fat in the trunk and extremities has both a superficial and deep fatty layer. The superficial layer is composed of small dense pockets of fat separated by vertical, well-organized fibrous septa. The deeper fat layer is organized more loosely, with looser areolar fatty tissue interspersed with less regular facial septae intervening between the pockets. The deep fat reserve is very difficult to lose through dieting and appears to be of genetic origin. The areas are perfectly delimited anatomically: love handles, saddlebags, internal face of the knees. They resist weight loss by sports activity. It is easy and safe to remove this deep fat by aspiration. The superficial fat is very rich in blood vessels and is responsible for the phenomenon of cellulite. This metabolic fat, easy to lose or gain, is not limited anatomically, it is diffuse and thus difficult to aspirate. Suctioning in the superficial layer allows the surgeon to achieve subtle benefits in the procedure but, because of its superficial location, increases the risks of contour irregularities and injury to the skin, so it is very technique dependent. Aspiration of the layer is often disappointing or even discouraged. Some authors, on the other hand, claim that superficial liposuction enhances skin retraction. Liposuction is mainly used to correct deep and superficial fat accumulations and remodel the body contour. It has become an essential complementary technique to enhance the aesthetic result of many other aesthetic procedures such as cervicoplasty, reduction or augmentation mammoplasty, abdominoplasty, brachioplasty, thigh lift, and post-bariatric body contouring. One of the first non-cosmetic clinical applications of liposuction was the aspiration of a large lipoma without leaving a visible scar. Hypertrophic insulin lipodystrophy may benefit from suction-associated lipectomy. Cervicodorsal lipodystrophy is another secondary lipodystrophy in which liposuction is needed to achieve satisfactory results. Liposuction subcutaneous mastectomy is the initial surgical approach of choice for pseudogynecomastia and gynecomastia. In female macromastia and gigantomastia, there is an important increase in breast fat component. Liposuction combined with traditional resection mammoplasty allows volume reduction before excision and refining the results after the reconstruction with an easier surgical procedure and better aesthetic results. In chronic lymphedema, the increase in volume of the area is mainly due to the accumulation of adipose tissue and not fluid. Liposuction provides good aesthetic and functional long-term results with a minimum complications rate. Liposuction allows remodeling of the musculocutaneous and fasciocutaneous flaps, through thinning the subcutaneous tissue, usually without the risk of flap necrosis. It also reduces the number of revision procedures required to achieve optimal aesthetic and functional result. Other less common clinical applications include axillary hyperhidrosis, revision of surgical scars, sexual dysfunctions, and genital area, e.g. the buried penis in fatty men. Liposuction is also used to facilitate tracheostomy, colostomy, and urostomy in great obese patients, in which the stoma could be occluded by excessive fatty tissue surrounding. Main indications of liposuction procedure: lipoma and multiple lipomatosis, lipoedema and lipodystrophy, insulin-induced lipodystrophy, gynecomastia, macromastia, and gigantomastia, post-bariatric body contouring, musculocutaneous or fasciocutaneous flaps management, scar revision, genital area and sexual dysfunction, tracheostomy, colostomy, and urostomy management, axillary hyperhidrosis, aesthetic body contouring. Patient selection. Patient selection is of major importance and might be the most critical factor for a safe and aesthetically satisfying result in body contouring. Not all patients who request liposuction are good candidates. In 2004, the Committee on Patient Safety of the American Society of Plastic Surgeons published the first practice advisory on liposuction to help guide appropriate selection and treatment of patients seeking liposuction, which was subsequently updated in 2009. Patients should be generally healthy and demonstrate a commitment to long-term lifestyle changes including both healthy diet and exercise. Patient goals and expectations should be appropriate and realistic. Patients who are obese, adolescents, and patients with certain pre-existing medical conditions may not be suitable candidates. For liposuction candidates, 6 key elements should be documented. Evaluation of areas of lipodystrophy and contour deformities. Skin tone and quality. Asymmetries. Dimpling and cellulite. Myofascial support. Zones of adherence. Anatomic zones of adherence, marked in red. Of these, the most important is the gluteal crease, which should never be violated. Commonly treated areas for liposuction are marked in blue. The anatomic zones of adherence, which are present in both men and women, are important to identify preoperatively. These are areas of relative dense fibrous attachment to underlying deep fascia, and they help define the natural shape and curve the body. It is important to recognize these zones, as they are at high risk for contour irregularities after surgical intervention if not properly respected. Scheme drawn by ILAs to explain the different level of difficulty: green, forgiving areas; orange, difficult areas; red, forbidden areas; and dark, absolutely taboo. Criteria for selection of patients: good skin tone, smooth skin surfaces, no waves, depressions, or cellulite. Older patients willing to settle for a modest improvement. Surgical technique. Preoperative evaluation. Physician-patient dialogue is paramount in this evaluation. Understanding patients' goals and setting expectations is key. This can be supplemented with adequate patient education regarding preparation for surgery, the details of the surgery, potential risks and complications, and the expected postoperative recovery period. Physical examination should be conducted with specific attention to skin tone and quality, the presence of scars, hernias, asymmetries, dimpling or cellulite, location of fat deposits, areas of adherence, and perceived deviations from the ideal gender-specific contour. With recognition of the increased risks of large-volume liposuction related to fluid shifts and lidocaine toxicity, American Society of Plastic and Reconstructive Surgeons recommends that large-volume liposuction be performed in an accredited/licensed facility and that overnight monitoring of postoperative vitals and urine output be performed. Attention should be paid towards staging procedures or avoiding combining large-volume liposuction with other procedures. Marking. The patient is marked standing in the photo suite and in front of a mirror, if possible, with the following 2 goals in mind. Circumscribing the area to be defatted. The markings can be doubled. The inner circumferential line indicates the exact area of demarcation between the suctioned and unsuctioned area. A second outer marking will then indicate an area of feathering, which is necessary to obtain a proper draping of the skin around the suctioned out area, preventing a step-down effect at the junction of the 2 zones of the skin. Feathering is usually done by the to-and-through movement of the cannula with mild suction applied to the tubing. The second purpose of the markings is to indicate the areas needing most of the treatment as well as the areas needing little or no treatment. Markings of target areas for liposuction, concentric circles, and surrounding transforming zones, straight lines. The markings, being the result of physical examination, should not be modified on the operating table since that would create a problem after the skin has shifted to a different position. A. Different incisions that can be used on the anteriorly. B. Posterior incisions. These incision markings should be made carefully and symmetrically to obtain similar results. These incisions are used for liposuction in any area of the body. Patient positioning. In some authors' experience, up to 75% of the liposuction procedure can be performed in this position. Appropriate padding of the hips, breasts, neck, and face/orbits is crucial to preventing avoidable intraoperative or postoperative complications. Cannulas. In general, blunt-tip cannulas are used to minimize perforation risk, and smaller diameter cannulas are used to minimize contour irregularities. Non-blunt-tip cannulas are typically used for breaking up scar or discontinuous undermining. Aspiration has been found to be directly proportional to cannula and suction tubing diameter and inversely proportional to cannula and suction tubing length. Beck et al. Found multiport and dual-port cannulas to be significantly more efficient at aspiration compared with the standard Mercedes tip cannula. Cannula position. Using the non-dominant hand to gently palpate the skin is necessary to maintain constant awareness of tip position. When treating areas on the trunk, it is important to carefully control the depth and direction of the cannula to avoid intrathoracic or intra-abdominal injury. One must be extremely conscientious for any encountered resistance, which should be managed by adjusting the direction of cannula. Anesthesia. Infiltration techniques.